Let's talk about a fascinating little molecule called apolipoprotein A, also known as Lp(a). This molecule has gotten a lot of attention lately because there are multiple medications in the pipeline, currently one in phase 3 clinical trials focused on lowering this protein, this apolipoprotein. The reason why this has become a focus is because it has been associated with elevated risk for atherosclerosis, elevated risk for stroke, for aortic valve stenosis, and thromboembolic problems. This was first discovered in the 1960s when testing was being done to look at the LDL particle and to determine what makes up the LDL particle. In the 80s, some epidemiologic studies associated it with adverse outcomes in some of these conditions. It was determined that there was really nothing that could be done to impact it. Diet and exercise wouldn't do it, and it was implicated highly in genetically determined family history of atherosclerosis and early heart attack. What's fascinating about this molecule is that as we've learned more about it, we've learned that it has an evolutionary advantage. In prehistoric times, when we were dying of trauma, and when we had more injury, Lp(a) served a purpose. This was a molecule, or is a molecule, that has the capacity to reduce the amount of breakdown of blood clots. Our body has a process. We make a blood clot and we can break it down. Lp(a) maintains that. It's like a homing missile. It will deliver LDLs to an area of vascular injury. And what that does is it stimulates the immune system at that location to help heal faster. It also will stimulate what's called the extracellular matrix to help heal faster and create inflammation in tissue. So it's got a lot of healing properties. There's evidence that it can mop up inflammatory compounds that may leak in from our gut. The problem is that it was designed as an emergency response tool to help heal, but not to stay sustained for long-term chronic situations. And that's the situation we find ourselves in today. We don't die as frequently from injury or infection, and now chronic inflammation and low-grade damage to our vascular system from various insults will stimulate this protein to go to that source, to go to those areas of injury and stimulate inflammation. Now, that injury is not life-threatening, but it's enough to stimulate a response from this Lp(a) protein and deliver and trigger inflammatory compounds. If you have Lp(a), does that make you destined to have these conditions? I don't believe that's necessarily true, and we still don't know everything there is to know about Lp(a). There are people that have elevated Lp(a), and they show no signs of any of these adverse outcomes. So what is it that they have? We don't quite know. What we do know is that if you have Lp(a) and you do have atherosclerosis or history of a stroke or calcification on your aortic valve, then you're a person that's at risk, and we need to focus on lowering that Lp(a). Currently, there's very few medications that directly lower it, and the thinking is because it's attached to LDLs, then the next best thing we can do is lower the total amount of LDL. And if we lower that total amount of LDL, we lower the amount of Lp(a), and we lower what the Lp(a) is trying to deliver. The two medications that are used most currently, a statin is going to have variable effects. Studies show it's unreliable in lowering Lp(a), but it will lower LDLs. The other medication is a PCSK9 inhibitor. Now that does show up to a 20 to 30% reduction in Lp(a) directly. If we're not going to use pharmaceuticals, then we could potentially look at other off-label compounds. Estradiol has some data to show that it may lower Lp(a), and so does testosterone. There are some compounds, polymethoxyflavonoids, tangeretin and nobelatin, or those two, come from citrus peel extracts, and those may potentially lower Lp(a) in combination with other medications. There is anecdotal data of other compounds, but we really don't have a great Lp(a) lowering agent, and this is why pharmaceutical agents are being researched. The data is showing that these agents can lower Lp(a), but we're still waiting for outcomes data. And what that means is we're still waiting to see if that makes a difference in these patients. What good is it to lower Lp(a) if we're not reducing the amount of heart attacks or reducing the amount of aortic stenosis or strokes? So that data has yet to come out, and until then, holding out any hope that this is the magic bullet for Lp(a), I think the outcomes data are what we're all waiting for to see if it's really the agent we're hoping it is.